Hello, everyone, and welcome to our group presentation on non-Hodgkin's lymphoma regarding the clinical research of it and ibrutinib. To further dive into non-Hodgkin's lymphoma, we should first look at the basic biology and components that make it what it is. So first, let's begin by talking about the tissue. Non-Hodgkin's lymphoma, or NHL, can begin in the lymph nodes or the lymph tissue. The vital sites of the lymph tissue are such as the lymph nodes, spleen, bone marrow, thymus, adenoids, and tonsils, and the digestive tract. Regarding the cell type origin, there are two main lymphocytes, which are B lymphocytes, also known as B cells, and there are T lymphocytes that are also known as T cells. B cells typically helps one's body against any viruses or bacteria. They do this by making proteins that go by the name of antibodies. T cells, different from B cells, come in variations. Some T cells destroy bacteria or viruses, or even any abnormal cells that are within the body. Some other T cells can even assist in boosting or slowing down the activity of other cells in the immune system. The type of tumors that are found in non-Hodgkin's lymphoma are a massive and heterogeneous institution of solid tumors of the lymphoid tissues. Types of non-Hodgkin's lymphoma can be grouped on whether they're an aggressive subtype or a slow-growing subtype. Aggressive lymphoma subtypes tend to spread and grow quickly and need immediate treatment. Within the United States, the most common is diffuse large B-cell lymphoma. There are also others such as mantle cell lymphoma and Burkitt lymphoma, etc. There's plenty. Then there's slow growing lymphoma, which are different subtypes than aggressive lymphoma subtypes, as they tend to spread and grow very slowly. And they don't need immediate attention, but they have to be observed very closely. Follicular lymphoma is the most common type within the United States. And then there's others such as marginal zone B-cell lymphoma, etc. There's also plenty of those. Now, let's move on and discuss mutation of tumor suppressor gene consequences. Krupel-like factor 4, also known as KLF4, which is what I'll refer to it now on as it is a mouthful. This is what can also be known as a tumor suppressor gene within non-Hodgkin's lymphoma, and it can also be seen as an oncogene in pre-B and T cell lymphoma. Gene function, when discussing KLF4, hinders cell division for any damaged DNA, as it also regulates chromosome number or genetic stability. There are effects when it comes to tumor promoting inflammation as an arising hallmark of cancer, as overexpression of KLF4 can promote inflammation and lead to inflammation-mediated esophageal squamous within cell cancer. Familiar genes to KLF4 that also have context-dependent roles within cancer are Notch1 and CDKN1A.
Okay, so my name is Vivian Villarreal, and I will be talking about the hallmark that is targeted with this cancer. So the hallmark that we found was the most targeted is the tumor promoting inflammation hallmark, which is known as an enabling hallmark. And so what happens with this and the process that occurs when this is targeted is that it will result in a histamine release, which will then increase the permeability of blood vessels, which will then result into metastatic spread. And metastatic spread is when parts of the original tumor begin to spread to other parts of the body. This further indicates that this is a proto-oncogene because it will accelerate the cell division, which will trigger angiogenesis, which again is the development of new blood vessels, which will then, increase the metastatic spread because the blood vessels will grow and will cause inflammation and spread towards other organs or areas of the body. So the goal again is for this blood to target the BTK and inhibit the excessive amount of proliferation that occurs when the tumor promoting inflammation is targeted. And then the mutations primarily occur on your somatic cells, which will be DNA mutations that occur post conception. So these are mutations that occur and will develop over time. You are not necessarily born with them. They're just mutations that begin to happen over time.
All right, so my name is Will, and I'm going to talk about the epidemiology of non-Hodgkin's lymphoma, or NHL. All right, so first of all, I'm not going to read off all the slides, all the information on the slides because of time constraints. So this information right here is gotten from SEER. Here's the estimated cases in 2022, which is 4.2% of all estimated cancer cases, and there will be 3.3% of all deaths are going to be from NHL. Once again, this is estimated because 2022 is not over with. And all this information, or this information here on the left, sorry, is age adjusted and it's for all races and in all sexes. All right, so if you see, look at the mortality rate, it's actually been decreasing over the years. All right, so it is estimated that NHL is going to be the 7th most common new cancer or most cancer cases of 2022. All right, so who gets NHL? And this is per 100,000 people, and this is age information as well. Males are flat out more likely to get it, but the most likely are white males, and the average age is 67. Who dies? Once again, this is from SEER, and this is age adjusted as well. Most likely are men compared to women, and white males are more likely to die. The average age of death is 76. So the average age of diagnosis is 67, but compare that to 76, that's much better than the 5-year survival rate. All right, so where is NHL found in the US? And this is from the Cancer Society. And right here is the incidence rates and death rates. They are 2 different 4-year spans. And the most likely for incidence rates are New York and Florida. And here's the most likely. There's a lot of different, more likely death rates for NHL. And the reason I won't worry about these 2 different spans is because if you look at the incidence report over the years, it's been relatively steady. All right, so where is it found worldwide? This is where this information was gotten from. Most likely is Israel, which is about 16 per 100,000. Compare that to the US, which is second, is 13. So the question is asked, is this a public health concern? And the answer is yes. If you look at 13 per 100,000, if you go to Zimmer Center right here in New Hanover, right now there's going to be about 13, maybe more due to our older population that has NHL. So yes, this is a public health concern. All right, so let's talk about risk factors for NHL. Here are some non-modifiable risk factors. Here are some modifiable risk factors, but the one I'm going to talk about is HIV. The reason is because I don't want to talk about something that we cannot change. And even though these are technically modifiable, if people aren't going to change their diet, their tobacco or alcohol usage for more apparent acute diseases, they're not going to change it for NHL. HIV, though, if we can find a cure for HIV, we can actually lower the number of NHL incidents. And the reason I believe this, because multiple studies, but this one in particular, which was published by Walter Kluwer Publishing, had a study that is titled Non-Hodgkin Lymphoma Risk in Adults Living with HIV Across 5 Continents. Here is your author. This was an observational cohort study. This is the number of adults with 1.1 million person years used in the trial. And it followed ART patients. ART is the therapy that is used in HIV. For HIV patients. All right, here's everything that is adjusted for, and below is a link. All right, so what we have here is the crude information and the adjusted information. And what we are setting the standard for are heterosexual men and people who do not inject drugs. That is what PWID stands for. All right, so what everything was adjusted for is right here at the bottom. And we set these standard because we're trying to see if there's a difference in people with HIV, and the most likely causes of HIV are men having sex with men or intravenous drug usage. All right, so what we found is significant because in the parentheses is a 95% confidence confidence interval is that men having sex with men are more likely to have NHL than heterosexual men. All right. So some other findings of the study, there's not a graph for it within the study, was that people who were on ART or therapy was out of 100,000, 142 of them had NHL. Compare that to the general population of 10 out of 100,000. That is a significant difference. That is 14 times difference. So 14 times more likely if you have HIV, because that is the only ones who are on ART. If you have the HIV, you are that 14 times more likely to get NHL. That is very significant. So if we find a cure for HIV, we lower the incidence for NHL. All right. Well, that is my little bit. Thank you so much for listening.
Okay, so the big question is ibrutinib worth it? So I would overall say it definitely is. I looked through quite a handful of intervention studies, but the one I'll talk about is by pubmed.gov. It's presented by them, and it's with Dr. Anas Yunus and some collaborating authors. So their study specified on looking at patients who had already had this sort of lymphoma in the past, and it was to test the safety and effectiveness of this drug in combination with some other treatments, as it's recommended to be taken with some other cancer preventative or treatment. And so given that this cancer had already run through this patient's bodies, it still on average had an over 60% effectiveness on the majority of the patients, and it was seen to be very acceptable and very safe, regardless of how long you had to take the drug or your history of cancer in the past. The only main risks that they have seen, and that is pretty common to see, anywhere around 30 to 50% of the patients will show these signs and risks or side effects are diarrhea, nausea, fatigue, dizziness, just kind of abdominal problems. It tends to make people have an upset stomach. But other than that, there has been no long-term effects that have been seen and proven to occur because of this drug. So again, it is very safe to ingest. And of course, the main benefit is that it will incredibly decrease the lymphoma in these patients. And so another big question is the cost. So it is quite pricey. A 28-day supply or 1 month supply of the oral tablet of this drug is around $13,000. The patients that had the highest survival rate didn't stop taking this drug until after an 8-month period, on average. So you have to take into consideration that those $13,000 will be paid every month. Fortunately, though, it is usually covered by insurance. Another thing to take into consideration is that this is recommended to be taken with something else, and that other treatment can be even more costly as well. So it does come in hand with another thing. Which is why I think specifically with this drug, it is very important for the physician to be very careful with their patient specific treatment, only because I again read quite a handful of intervention studies, and I was able to see how there are so many subgroups that are within this specific cancer because it is affecting your genes. And so certain genes react differently to different treatments. And for example, they compared a certain set of genes, two sets of genes with this drug and chemotherapy, and one of them was super effective and the other one was made the cancer worse. So again, this all goes into play with what the patient specific treatment will be. But in general, it is an incredibly effective drug. It does what it needs to do without causing further issues. Of course, any sort of cancer treatment can run the risk of secondary cancers or other problems, especially with the blood. But overall, there wasn't anything to necessarily worry about when it came to this drug.
This section will focus on clinical research of non-Hodgkin's lymphoma and ibrutinib. Strangely enough, the clinical and biological subtypes of non-Hodgkin's lymphoma are the same, with the three main subtypes being B-cell, T-cell, and NK cell lymphoma. Ibrutinib specifically targets B-cell lymphoma, so this section of the presentation will have a focus on B-cell lymphomas. The subtypes of B-cell lymphoma most commonly treated with ibrutinib include mantle cell lymphoma, marginal cell lymphoma, and small lymphocytic lymphoma, but many studies in ibrutinib have been conducted on chronic lymphocytic leukemia patients, which despite having leukemia in the name, is a form of B-cell non-Hodgkin's lymphoma. There are many symptoms and side effects that need to be taken into account when treating non-Hodgkin's lymphoma with ibrutinib, and some of those are listed below. According to data from SEER, the relative 5-year survival rate of non-Hodgkin's lymphoma is 73%. That means that people with non-Hodgkin's lymphoma are only 73% as likely to live 5 years as those without. The main factors that affect this 5-year survival are age, stage of lymphoma, presence or absence of metastases, whether or not a patient can remain active, and blood level of lactate dehydrogenase, which is heightened when the amount of lymphoma in the body increases. A considerable amount of the time, non-Hodgkin's lymphoma is already in stage 4 by the time of diagnosis, and while the difference in screening programs contributes in part to this difference, breast cancer is nearly 3 times more likely to be localized when discovered than non-Hodgkin's lymphoma. In a 2019 study, ibrutinib was shown for chronic lymphocytic leukemia to have a 5-year progression-free survival of about 70%, compared to 12% for the competing drug chlorambucil. The 5-year overall survival was also impressive at 83% compared to 68%, and the overall response was around 92%, suggesting that only 8% of participants in the study were completely resistant to the drug's effects. An intervention study held last year on chronic lymphocytic leukemia, patients found that when combined with obinutuzumab, a drug often used in combination therapy for certain lymphomas, as well as additional treatments depending on the response of the tumor, the 3-year progression-free survival rate was around 95%, and overall survival was 98%. There are also countless other combinations of drugs, including chemoimmunotherapies, targeted agents, and monoclonal antibodies that are used to treat non-Hodgkin's lymphoma with ibrutinib. Ibrutinib is designed to specifically work against lymphomas of the B cells, so it will not work against T cell or NK cell lymphoma. Another thing worth considering is the brain's lymphatic system, the glymphatic system, which may be of importance to the treatment. Ibrutinib is cytotoxic to the cancers that it treats, and through its interactions with Bruton's tyrosine kinase, it causes cell death. In a 2015 study, patients took ibrutinib for as few as 2 months or as long as 39, and because the drug is cytotoxic, a portion of the patients are able to stop taking the drug. However, according to the same study, the median survival after stopping treatment was only 3 months, but it is unclear how many of these patients stopped treatment because they would have died anyway, and how many died because they stopped. Bruton's tyrosine kinase is involved with growth signaling of B cells. A receptor on the surface of these cells signals the release of tyrosine protein kinases SYK, FYN, and LYN, and these activate Bruton's tyrosine kinase during the growth signaling of B cells. Bruton's tyrosine kinase is an oncogene, which many lymphomas having an excess number of these tyrosine kinases, which increases proliferative signaling, and allows us to target it specifically. Because it targets a growth factor receptor, ibrutinib is a cell-cycle non-specific treatment. Because it targets a tyrosine kinase, it is much more likely to target cancer cells, but ibrutinib can still target healthy cells, which do not have the excessive amount of oncogenes. This would cause off-target effects, and according to this study, ibrutinibs have 3 major off-target effects, which have different effects on the body. Thank you for watching, and I hope you have a great day.